I would like to introduce our next presenter, and I'm honored to have him join this training. Daniel Dobovsky, MSW, is a clinician who has worked in the field of mental health for over 40 years across various clinical settings. He's the former head of the FASD Center of Excellence, which is SAMHSA, Health and Human Services. He's an internationally recognized for his expertise in fetal alcohol spectrum disorder and mental health, and he currently works as a consultant for FASD. Mr. Dobovsky.
Thank you very much, Peg. I appreciate that. I wasn't the head of the FASD Center for Excellence. I was just the FASD specialist for the center.
All right, thank you.
So, but I appreciate being here, and I appreciate, let's see. Okay. Here we go. And I appreciate having the opportunity to talk with you. I encourage you to type in questions as I go along, and I've asked Peg or Ann to interrupt me with the questions as we go through this. I did see a question at the end of Peg's talk about the fact that a lot of these kids end up in regular education. I would say that unfortunately or fortunately, depending on how you look at it, many youth with an FASD also have other issues that would really allow them to be seen as needing an IEP. And the IEPs are really important in terms of, especially if somebody recognizes the FASD, in terms, again, of modifying approaches so that they can be more successful. And that's really all of our goal as parents and as practitioners. Our goal is the same, which really is to help people function optimally, to reach their best potential. And I think that that's our goal for all of us. So a lot of what I'm going to say really kind of reiterates what Peg just said, but sometimes it's good to hear things more than once. So this is my contact information. Again, as Peg said, I'm currently a consultant and work at various places around the country and Canada, doing training and technical assistance around FASD. The other thing that happened was that a couple of colleagues in mine and myself, about now, let's see, maybe close to 10 years ago, developed a screen to identify individuals with a probable FASD, because we recognize that many times we don't have the information about prenatal alcohol exposure. And as Peg said, the only diagnosis that you can get right now without knowing that is full fetal alcohol syndrome, which is, as she said, vast majority, minority of those, minority, maybe 10, 15% of those with an FASD. And it's actually those without full FAS who have more difficulties, because often they look okay, they sound okay, they have an above average IQ, so we expect more of them. So we developed a screen that would identify them. And in Germany, 2 women who were doing their thesis wanted to validate the screen. It's called the Life History Screen, and found that it was about 92.8% accurate in identifying those with and without an FASD, which to me was very, very exciting. So that we might not then get a diagnosis because it's not diagnostic, but we can say this is a probable FASD, and therefore we need to do something different. This is how I got involved in FASD 35 years ago, and this is my son, Bill. And when Bill was 7 years old, I brought him to a neurologist to try to find out why he was having some of the problems he was having. He didn't do well in school, and we have this, I think it's a very strange approach that people need to fail at something before we talk about what they may need in order to succeed. So we're constantly setting people up to fail. As kids, as adolescents, as adults, we're setting them up to fail in that way. So I went to his school when he was in first grade, and I said he needs a small special education class. And they said, well, we'll put him in a regular class first. If he doesn't do well there, then we'll talk about another class for him. Of course, he didn't do well in a regular education class. So they put him in a small special education class with acting out kids. What I've learned over the years, the worst class for a kid with an FASD is a small special education class with acting out kids. Because one of the things we know in FASD is that people with FASD tend to learn best by modeling the behavior of those around them. Not by being told what to do, not by being shown what to do, not by being consequenced for not doing it, but by modeling. So you put them in a class with acting out kids, they'll model the behavior of the other kids in the class. And that's exactly what he did. So he didn't do well in school. He didn't do well with his peers in the neighborhood. And the clincher for me was he wasn't responding to my amazing parenting techniques. So I figured there's got to be something wrong with him. It couldn't possibly be me. The neurologist did a cursory neurological exam and she said, does he drink? And I said, no, I don't think so. I hope not. He's only 7. Why would you ask me if he drinks? And she said, well, his reflexes are different. And that's usually indicative of drug or alcohol use in an individual or in their parents. And that was 1982. There was very little I could find out about it. And for the next 7 years, we really struggled. He started gathering diagnoses, which you'll see later, like reactive attachment disorder, oppositional defiant disorder, ADHD. The treatments were not effective, so he was labeled as being non-compliant, uncooperative, resistant, manipulative, and unmotivated, what I call NERMU. And it really wasn't until 1989 when an aunt of mine called me up one day and she said, I just read this book and I think you should read it. It's called The Broken Cord. And The Broken Cord was written by Michael Doris and published in 1989. And it was the first popular book on FAS. He adopted a son from the Midwest, brought his son home. His son had lots of problems. He couldn't figure out why. He went back to the community from which he adopted his son, and they began to talk with him about FAS because there were a number of people in that community who had been identified as having FAS, fetal alcohol syndrome. Lots of people have read that book over the years and said it's so depressing because Michael only talked about all the problems with his son. He didn't talk about any of the joys. I read the book and it was incredibly validating because everything in the book, I said, this is Bill. This sounds just like Bill. And finally, at 15 years old, his behaviors that had been labeled as willful, purposeful behaviors that needed to be consequenced for so many years began to make sense. Now, he still didn't get his diagnosis, and he got a diagnosis of FAS when he was 19 years old from 2 separate psychiatrists, actually. That meant 19 years of failing in every system of care. And one of the things in the book that I like talking about because it's so indicative of FASD is that Michael and his wife went out for dinner one night. They came home from dinner. There was an inch or 2 of water on the kitchen floor and water pouring down from the ceiling. Michael went upstairs to the bathroom. He opened up the bathroom door, turned on the light, and there was water pouring out of one of the pipes that was running along the floor in the bathroom. He went into his son's room. He woke up his son. He said, what happened? His son said, I didn't do anything. Good adolescent response from any adolescent. Michael said, did you stand on the pipes and break them? And his son said, yes, but I did what I was told. Michael said, what's that? And his son said, every time I leave a room, I'm supposed to turn off the light and close the door. And I did that. Now, if you don't understand FASD, you would say his son was lying about what he did and covering up something he did wrong, and he would have to be consequenced for it. And you would be absolutely wrong. Because for months and months, Michael drummed into his son's head, every time you leave a room, you turn off the light and close the door. Every time you leave a room, you turn off the light and close the door. And his son finally got it, but couldn't figure out in this situation when the pipe was broken, he needed to do something different. So he thought he was doing exactly what he was supposed to do. Now, that made sense to me because I would come home from work, Bill would be nowhere to be found, the door to our house would be wide open. And we didn't live in a neighborhood where that was a good idea. So he would come home and I would say, Bill, every time you leave the house, you have to lock the door. I would come home from work. He would be nowhere to be found. Door would be unlocked. He would come home. Clearly, this was purposeful behavior. So I kept consequencing him for it. And he kept doing the same thing. Now, one of the ideas is if a consequence doesn't change behavior, it's not the right approach. It's not the right consequence. It's not the right approach. We need something different. I didn't learn that back then. I'm definitely from the do as I say, not as I did school of thought, because I made lots of mistakes, even after he was diagnosed, but especially before. So finally, after a long time of doing that and a long time of getting consequences, we would go to take the garbage out and come back into the house and the door would be locked. You know, this is just an obnoxious adolescent getting back at me because I've been punishing him. We would go into the backyard, come to get back in the house, door would be locked. And of course, what I know now is that that wasn't it at all. He wasn't doing this on purpose. He finally got it. Every time I leave the room, I have to lock. Every time I leave the house, I have to lock the door, but couldn't figure out when you're this far away, you don't have to lock the door. When you're this far away, you do. Because the part, and this is a brain issue, as Peg said, and that's so important to recognize. And I'll talk much more about it. But the part of the brain that's responsible for figuring out what to do in a specific situation is damaged by prenatal alcohol exposure. So the idea of teaching a student something in school and the fact that they will be able to take that and use it in another setting is setting them up to fail. The idea that a parent might say to their child, every time you get to the corner, you have to stop, look both ways, make sure nobody's coming before you cross the street. And the parent might take the youth out and practice that. Get to the corner, stop, look both ways. Is anyone coming? No, okay, then we can cross the street. Then you look out and you find them crossing the street in the middle of the block without even looking. And you may say to them, didn't I tell you to stop and look both ways before you cross the street? They may well say, you told me when I was at the corner to stop and look both ways. I wasn't at the corner. And it feels like manipulative behavior. That's one of the problems with FASD. The behaviors feel so willful and purposeful. And they're not, as Peg said. So I really thank Bill because he taught me to think differently about behavior. And that's really important. And again, I'll talk a little bit more about that. The other piece is that nobody would see him in their program. Nobody would see him in school and say, this is a young man with this disability. Verbal, talkative, he could repeat what he needs to do. He could repeat the rule, he just couldn't do it. He couldn't operationalize it. So it all looked like purposeful behavior. He was just lazy. He was just non-compliant, uncooperative, resistant, manipulative, and unmotivated. And, you know, when he got to school, in middle school, he came home one day and he said, Dad, he said, every day I walk into school, I feel stupid. Well, you know, most of us would not put ourselves in a situation where we feel stupid every day. So either get thrown out of school or truant, because that's way too painful. So the other thing that Bill taught me is how emotionally painful it is to live with a hidden disability that nobody recognizes, to be told over and over and over again, you can do this if you want, you're just not trying hard enough. If you try hard and you really pay attention, you can do it. You did it yesterday, clearly you can do it again today. And he could get 100 on a spelling test on Monday and spell every word wrong on Tuesday. And it just looks and feels like manipulative behavior. He's just lazy, he's just not paying attention. And again, in FASD, that's not it at all. So again, I thank Bill for teaching me to think differently. As a therapist, I remember people who would come into my office, put their head down, pull their coat or their hat over their face, and I would write in their chart, poor eye contact, not motivated for treatment. Not recognizing that some of them couldn't tolerate the fluorescent lights in my office. Fluorescent lights are really tough for many individuals with FASD. I don't think I've ever seen a classroom that didn't have fluorescent lights. I never worked in an office that didn't have fluorescent lights. They hear the buzzing in the lights. They see the flickering in the lights, even when we don't. The lights are too bright, but they can't articulate that's what's bothering them. So the youngster in school who's bothered by the lights may crawl under their desk, put their head down, jump out of their seat, run around the room, flick the light switch on and off, and they're just seen as a disruptive child, and nobody stops to say, could this be a sensory issue? So that's really important. That's really key to recognize. So every system of care is impacted by FASD. And many systems don't think that they are. And, you know, the difficulty with many of these systems, and again, I've been a mental health clinician for over 40 years in various settings. I worked in residential treatment, I worked in hospital settings, I worked in outpatient treatment, family service agencies, and, you know, whatever role you're in, a teacher, an aide, a counselor, a therapist, a psychologist, a psychiatrist, whatever the role you're in, you're taught certain ways of doing things. And it's hard to kind of say, not everybody works that way. Not everybody benefits from that. So that's really been a struggle for every one of these systems. And it's easier to say, no, I don't see anybody with FASD. And their image is somebody with an IQ maybe under 70, who may be small in stature, who may have certain physical features. And if they don't see that, they're not seeing anyone with FASD. So in terms of mental health, again, Ann Streiskuth's study, four-year study done for the CDC that was published in 1996, identified that over 90% of those with an FASD had co-occurring mental health issues. Now, this is one study, and I always say this with the Ann Streiskuth's secondary disability study. This is one study that was done in a clinic with 451 people diagnosed with an FASD, but it's only one study and it's a clinic-based study. So we can't say that overall 90% of people with an FASD have co-occurring mental health issues, because we don't know how many people are living with FASD who are doing pretty well without co-occurring issues, and they haven't been identified, because we are terrible at diagnosing FASD because our diagnostic capacity is minuscule compared to the prevalence that I know Peg talked about. But then there was a study done by Susan Astley from the University of Washington that looked at birth mothers who gave birth to children with FAS, because she wanted to see, was there some pattern that they could pick up of these birth mothers so that they could intervene with them early in terms of prevention and in terms of support, not to put them in jail, but in a positive way. So what she found of these birth mothers were 100% of them had alcohol use histories. 96% of them had between 1 and 10 mental health diagnoses. So 77% of them had post-traumatic stress disorder, 59% had major depressive disorder episode, at least. 22% had a manic episode, documented manic episode or diagnosis of bipolar disorder, and 7% had schizophrenia. Now, one of the things we know about mood disorders, bipolar disorder and major depression and schizophrenia, along with ADHD, is that they are very highly genetically linked. So because I remember a parent saying to me one time at a conference, I have this sense that there are more people with FASD who have schizophrenia than the general population. And I said, you're probably right, but not because prenatal alcohol exposure causes schizophrenia, but because of this. So what happens is that if a parent has schizophrenia, for example, chances are 25% that a child will develop schizophrenia. If both parents have schizophrenia, then it goes up to over 50%. The same is true for mood disorders. If a parent has a major depressive disorder, chances are 25% a child will either have major depressive disorder or bipolar disorder. And if both parents have a mood disorder, it goes over 50%. Now, these are also disorders with high rates of co-occurring substance use, often to self-medicate. So my sense is with these birth parents is that who had these disorders is that often they use substances, and alcohol, of course, is our legal drug, is easiest to get and cheapest in many ways. Used alcohol, gave birth to a child with FAS with the genetic vulnerability for the disorder. And there's research that shows that one of the things that causes underlying genetic vulnerabilities to develop into full-blown disorders is the number of stressors they experience in their life and their ability to cope with stressors. Now, people with an FASD have incredible stressors from birth on, that failure to thrive and poor sucking reflex and, you know, sometimes malnutrition because they're not getting the nutrition, inconsistent caregiving sometimes. They don't do well in school. They don't do well in the neighborhood. They don't do well in social situations. Incredible stressors and poor coping mechanisms. So if they have a genetic vulnerability, they're more likely to develop the full-blown disorder. So these youngsters with FAS who were born from of these women, again, 7% of these women had schizophrenia. That means at least 7% of these kids had the genetic vulnerability for schizophrenia and would be more likely to develop schizophrenia when they got older. Now, it's probably even higher than that because she didn't, Susan Astley didn't look at birth fathers. She only looked at the mothers. But recognizing that, so we're going to see people, and what's going to happen is we're going to see youth now who get some of the diagnoses of mental health disorders, and we don't recognize the co-occurring FASD, and then we don't provide the right support for them. 95% of these birth mothers had been physically or sexually abused during their lifetime. And one of the things that they did not look at in this study was how many of these birth mothers themselves had an FASD, which would have been another interesting thing. But again, it's like, this is one of the reasons we're going to see more mental health issues in those with FASD. And 79% of them reported, there we go, 79% of them reported having a birth parent who had an alcohol problem. These are the women who gave birth to children with FAS. 79% of them said that one of their parents, birth parents, also had an alcohol problem. Again, they didn't go through diagnosing them for FASD, but we could suspect a high percentage. Oh, that's better. Okay. So what we see is that there are often co-occurring mental health and or substance use disorders. And again, as it says here, sometimes we misdiagnose. Oh, this looks like oppositional defiant disorder. We're diagnosing oppositional defiant disorder. Looks like autism. We'll just diagnose autism. And I will tell you that, well, I'll get to that. Never mind. So it may be a misdiagnosis. It may be an accurate co-occurrence. So they may, for example, have a true co-occurring bipolar disorder, but no matter what it is, the approach needs to be different, recognizing the FASD. So we need to do this thorough workup, a real medical evaluation, mental health assessment, a thorough family history, neuropsychological testing by somebody who understands FASD. Otherwise, it's not going to be terribly effective. And adaptive functioning testing. And then we really need to take those things in, because I know, as Peg said, that, you know, adaptive functioning is much more indicative of the issues in FASD than IQ is. And they've identified people with an IQ over 140, which is genius level, who have an FASD, who still can't follow 3 directions at once, who still can't get along in social situations and read social cues, and not because they're lazy, but because of how their brain is working. I remember Bill at 12 years old had some really good neuropsych testing done. And one of the things that stuck with me from that testing was never expect him to do expository writing. he can't do it. He could dictate something, but he can't sit and write something. Think about how often in school we expect youngsters to write something down. And I've gone to a lot of IEP meetings, not only with Bill as he was growing up, but also in the last 10 or 15 years with other families to support them. And at one point I was at a meeting with this one youngster, and the English teacher said that he kept getting zeros. They had to read books, and then they had to write a paragraph about the book in their notebook. And he loved to read. And he could tell you what he read. He could not write it down. And because he couldn't write it down, he kept getting zeros. And I remember saying, can he dictate something to his father and have his father write it? Can he dictate it into the computer, have the computer type it out? No, he has to write it in his notebook. And it's like not recognizing that inability. You know, they can tell it, they can talk it maybe. Bill could tell you a story, but he couldn't write it down. So getting really good testing helps, and especially neuropsychological testing can be really helpful, more than regular psych testing, because it will tell you the subtest scatter and where are there areas of strength and where are there areas of challenge that we need to modify how we approach them. So again, I already talked about this, and especially in correctional facilities, using substances. People think that people in jail don't use any substances. And my response is always, I guess you've never been in a correctional facility, because yes, they do get access and they can use it. So again, and I talked about the genetic component. So I already did that. I talked about the stressors. So I already covered this. So again, if somebody with an FASD has an underlying genetic vulnerability to something, they're more likely to develop that because of the stressors and the difficulty coping with stressors. So this is something that we developed for when I was working on Alaska's FASD 201 curriculum. This is a number of years ago, but it's think about this in terms of the individuals, the youth, or if you're working with adolescents or adults with whom you work, they feel they're constantly anxious. And they're anxious because of these other things here, because they're so frustrated. They are the ones, they want those points, they want those stars, they want those stickers, and they don't understand why they're not getting them, because they don't get cause and effect, because that's a brain issue. So not getting the stars, stickers, or points is not going to help them do what they need to do to get the stars, stickers, or points. They're always frustrated. At home, they're given timeouts repeatedly, which I think is one of the worst things to do for somebody with an FASD, because the concept of a timeout is you need a timeout to think about what you did and what you could do differently. And they're in timeout. They have no idea why they're there. They must just be bad. And then they develop this self-image of being the badass, because that's the only explanation for why they never get what they really want. So they're frustrated all the time. They're anxious so much. They're depressed because they keep failing and they don't understand why. Because their friends abandon them, because they get into trouble all the time and they don't understand why. So they isolate themselves, or others isolate them. And this is true for the whole family also. The whole family gets isolated. And once the family gets isolated because their kid's acting out, then the whole focus is on stopping that kid's behavior. And one thing that I'm going to reiterate, and more than once, is one of those last things that Peg said that is so important is in FASD, and you'll see it on one of the slides. In FASD, the focus is not changing a behavior. It's not going to work. The focus on with a lot of youngsters and adults is they need to change their behavior. So we're going to find what they like to do and we're going to take it away for bad behavior and give it to them for good behavior, and that's going to help motivate them to do the right thing. In FASD, we need to change the environment so they can be more successful, as opposed to changing the behavior. And hopefully I'll remember to give you an example of that when we get to that slide. They can't predict what's going to happen. This is why they get into trouble for the same thing for the fourth time. They're surprised they're in trouble because they can't predict, oh, the last time I did this, I got in trouble. If I do it again, I might get in trouble again. Now that increases the anxiety if you can't predict what's going to happen next. So they end up living in the moment. They suffer ongoing loss and grief, which is something we don't talk nearly enough about, is the ongoing losses that those with an FASD experience and their families experience. Every time a milestone is missed, it's another loss. Bill at 19 years old came to me, he said that all of my friends who are younger than I am have licenses, cars, and girlfriends, and I don't have any of those things. And my response was, oh, don't worry, Bill, you'll get all of that, because I didn't want him to feel bad. I'll tell you, that was the wrong response. I told you, do as I say, not as I did. But he always gave me lots of chances to get it right. So he came to me a month later, he said the same thing. And this time I got it right. And I said, let's talk about that, Bill. How does that feel? Must feel really bad. And then we could talk about what he did have and what he was good at. But those ongoing losses, which again, increase the depression and increase the anxiety and frustration. They don't understand their world. They don't understand, again, what's going on, why they keep failing, and how to do things differently without the right supports. And they have difficulties in everyday life. This is overwhelming for them. And again, I heard the last part of Nate Sheets' little talk there. And, if they can hold it together for 6 hours in school, when they come home, my thing is, don't ever, unless they love homework, no kid, but especially no kid with an FASD should sit down and start homework when they get home from school. I happen to think that kids with an FASD should not have homework because it's not going to be helpful to them. And what takes another kid an hour to do takes these kids 5 hours to do. And then they miss out on they need to chill out. They need to get rid of some of that energy. They've held it together for 6 hours. They need to do something fun, do something physical. So recognizing this, because this is the way they live. And we need to shift that so we can help them see some of the positives. So we're only going to get optimal outcomes when we accurately recognize what's going on with them. And again, one of the problems is that often we misdiagnose or we don't recognize the FASD or something else. We're not going to get the best outcomes. And that's going to affect their ability to learn. I mean, all of this around the mental health issues has to do with their ability to learn in school. And that's really key because, school is that time where for them to really learn kind of life lessons and history and everything that will help them as they get older in life, in addition to things like just skills that they'll take with them. So if they're not accurately diagnosed, if they're not getting the right treatment, that's going to affect their ability to learn. If we don't recognize the FASD, that's going to affect their ability to learn in school. So we have to be careful that we're not saying, oh, this is a mental health issue, this is not an education issue. Yes, it is an education issue. So up until the DSM-5 came out, the Diagnostic and Statistical Manual of Mental Disorders, there was nothing about the effects of prenatal alcohol exposure in the DSM. And when the DSM-4 came out, I wrote a letter to the American Psychiatric Association asking them why it wasn't in the DSM-4. And the letter I got back from the American Psychiatric Association was that the reason it wasn't in the DSM-4 was because it never came up. And there were a lot of families who said, we don't want it in the DSM, then people are going to think of it as a mental illness. And I said, you know, there are so many mental health issues that people with an FASD are dealing with, like the anxiety, like the depression, that we need to if we don't get mental health to recognize the FASD component, they're not going to provide the right treatment because they're going to use cognitive behavioral therapy or trauma-focused cognitive behavioral therapy or motivational interviewing or talk therapy, and it's not going to be effective. So it's important to get it into the DSM because that's the only time psychiatry is going to pay attention to it. So there was a group that really worked hard at getting something in the DSM-5, and we have 2 terms that ended up in the DSM-5. Now, the second one here, neurobehavioral disorder associated with prenatal alcohol exposure, is called NDPAE. A lot of people are talking about it. There was some really good articles written about criteria for NDPAE. That's in the section of the DSM-5 of syndromes for further study, which is good. There's a lot of good information there if you get a chance to read the DSM-5 around that. But as you see here, there are no numbers after that. Numbers have to do with codes, with billable codes. There is no billable code for NDPAE. But in the body of the DSM-5, where it's totally different than former DSMs, and it used to be a 5-axis diagnostic code, not anymore. They've restructured it. They've moved disorders around so that there is the first group of disorders are neurodevelopmental disorders. And one of them is so that's where you find autism, high functioning autism, ADHD, number of other disorders. And one of them is other specified neurodevelopmental disorder, which has a DSM code of 315.8. And the one in parentheses, which is actually the more important code, is the corollary code for the International Classification of Diseases, the ICD. And it's the ICD-10-CM. At that point, it was the ICD-10-CM. The reason that code in parentheses is more important is because before the ICD-10-CM came out, HIPAA said, in order to get a diagnosis treated and coded, you need an ICD-10-CM code. Because before this, every psychiatric diagnosis did not have a corollary ICD code, but now they do. So the example they give for other specified neurodevelopmental disorder in the DSM-5 is neurodevelopmental disorder associated with prenatal alcohol exposure, which some people are now calling NDDPAE. And I've had discussions because people say it's the same thing. We're just calling them both NDPAE. No, they would not put the same diagnosis in 2 separate places in the DSM-5. But this one is the one that has a billable code for insurance companies to pay for mental health treatment for somebody with an FASD. And I think that's what's really important to recognize, because we need to if we recognize the FASD, we recognize how the treatment needs to be modified. So if we recognize somebody as having an FASD, we recognize them as having a disability. Again, here's this youngster, IQ of 125, verbal, talkative, friendly. Clearly, all their behavior is willful and purposeful. If we recognize they have an FASD, we recognize them as having a disability. And therefore, we need to do something different with them. If they had a huge vision problem and they couldn't see, we would adapt our approach. We wouldn't force them to read a book. We may give them something in Braille. If they have a severe hearing impairment, we would not expect them to listen to a teacher talking and take notes and know what to do with that. We would make accommodations. We make accommodations for those physical disabilities. Well, this is a brain disability and we need to make accommodations to it. But the problem is it's hard to recognize it sometimes. But again, if we recognize the FASD, it also reduces some of the frustration and anger that, again, as a practitioner or a parent, we often feel because they're not doing what they're supposed to do. And they keep messing up and they keep doing the same thing over and over again. And why don't they get it? and they keep on, getting into difficulty. But when we recognize the FASD, it can help reduce some of that frustration and anger. I've told you 3 times already you have to do this. Do I have to tell you more? Yes, because of how their brain is working. We went over this yesterday. Do we have to go over it again today? The answer is yes, because every day is a new day. Understanding that helps reduce some of that anger and frustration. They are at high risk for abuse and trauma, but we can decrease that if we recognize the FASD, and you'll see why they are at such high risk for abuse and trauma. And then we can modify what we do and maybe question some of the diagnoses that they've gotten over time. So again, here, we need to modify the environment rather than expecting the individual to change their behavior. So we need to change, whether we are a parent, provider, a practitioner in any setting. We need to change what we do and how we do it so that they can be more successful. We also need to identify and build on their strengths and abilities. So we want to find out what they like to do, what they do well, as long as it's safe and legal. And have them do that on an ongoing basis. Don't use it as a reward for good behavior and take it away for bad behavior. We want to build their self-esteem and competence. So I'm going to give you an example, which we've used before in various settings. So we have a family that has a few kids, 3 or 4 kids, and 2 of the kids are around the same age, around 12 years old. And their typical day is, one of them's been adopted, one of them's a birth child, not that that matters at all. But every day when they come home from school, these two 12-year-olds get home, the first thing they need to do is take off their shoes, hang up their coat in the mudroom before they come into the house. And they always start a fight every day. They start a fight when they're when they're coming home from school. So what we might do is consequence them, right? We'll give them consequences. They can't go out and play. They have to start their homework right away. They lose their Nintendo time, whatever we come up with. And it doesn't change their behavior. They're still fighting every day when they come home from school. So that might be the typical approach we would do and be told to do. As parents, we're told to do that all the time by providers who don't understand FASD. They need to be consequenced. That's going to get them to change their behavior. We need to find the right consequence. That's going to get them to change their behavior. So what we might do differently to change the environment in this situation, rather than expecting them to change their behavior, is that one of these kids, one of the 12-year-olds, really, they have a dog and he loves the dog. He wants to be a dog trainer. He loves trying to training his dog. So instead, what we do is say, when you come home from school, the first thing you do is take out the dog. So they get home from school, he gets the dog and goes out. The other 12-year-old takes off his shoes and his coat, goes in, starts whatever he's doing in the afternoon. He comes back with the dog after taking him for a walk. Then he takes off his shoes, no more fights. That's changing, that's modifying the environment. So in a way to deal with the challenging behavior. And that's what we need to look at differently than we might with other youth. But there are really challenges in doing this. And again, I've been in this field for a long, long time. And I keep thinking, why are people so resistant? Why are we all so resistant, actually, in recognizing the impact of FASD? And I think these are some of the reasons. That it really does challenge the basic tenets of everything we've been taught as a parent or as a practitioner. Because we have been taught that people need to take responsibility for their actions and learn by experiencing the consequences of their actions. That's the basis of any reward and consequence system. And a point, star, sticker, level, privilege system, they're all reward and consequence systems. timeout is a reward and consequence system. Not everybody learns by experiencing the consequences of their actions. And for many with an FASD, all it does is set them up to fail. That's not the way they learn, but it's hard to let go of that. No, we were told this. We have to, but they do. And then we have to find, if we find the right motivating factor, they'll do what they need to do. So I will tell you that when Bill got into middle school, he had trouble bringing his homework assignments home. And at the same time, he was going to karate classes, and he loved karate. And we had a karate school right near us. And once you paid for the month, you could go as many times a week as you wanted. So I said to him, Bill, every day you come home, you bring your homework assignment home, you go to karate that day, right? He loved karate. This is going to motivate him to bring his homework assignments home. From that day on, he never brought his homework home and never went to karate again. That was a huge mistake. Again, this is before he got his diagnosis of FAS, but that was a huge mistake. He should have gone to karate every night before, no matter what happened in school. We have to separate school and home. Don't have families consequence kids at home for what happens in school. The school really needs to deal with that. And that's important for the school to be able to deal with. Then people's response was, well, he's obviously not really motivated to go to karate. No, he really was. I was just setting him up to fail. So not everybody learns by experiencing the consequences of their actions. I often say to teachers who use a point star or sticker system, if you are really married to that system and you cannot let that go, then I would like you to see that your skill as a teacher is ensuring that these kids get whatever stars or stickers or points that they need. Not that they need to do that on their own, but you need to make sure that they do that. Find something that they do well. Ask them to help with something that was great. You just got 4 stars, whatever it is. Because not getting the stars and not getting the reward is not going to get them to change their behavior. Because of this next statement, we think that people are in control of their behavior, meaning that they can choose to do the right thing when they want to. It works with a lot of people. Reward and consequence works with a lot of people. That's why we do it. It just doesn't work with most with an FASD. And often those with an FASD, they want to do the right thing and they can't do it without the right kinds of supports. And then I really loved what Peg said at the end there about enabling, because enabling is taken such a negative connotation. And we think that if we do something with them or for them, we're just enabling them and we're fostering dependency, and that's bad. And I remember hearing from a behavior specialist in school, this youngster needs to do these things on their own because that's the real world. And my response was, if he could do it all on his own, he wouldn't need our help and he wouldn't be in this setting. And while he's here, we need to provide whatever supports and whatever help he needs in order to do well. Also, if we recognize FASD, we have to confront our own biases about behavior, about drinking during pregnancy, about behaviors, meaning no, all behaviors are willful and purposeful, and the person can choose to do something different when they want to. May bring up issues in our own lives that we don't want to address because alcohol is so pervasive in our society. And then it's easier to look at the person as having to change. It's up to them. When they are ready, when they are motivated, they will do what we want them to do. You're putting it all on them. It's up to them. It's easier to do that because then we don't have to look at doing anything different, because needing to change our approach means we have to think differently, and that's hard to do. And we also think that we need to treat everybody the same. I can't treat this kid differently in my classroom than I treat the other kids because that's not fair. And they'll call me on it because we somehow think that fair and equal are interchangeable terms. This is a graphic that was actually shared at a conference by the Secretary of Health for the state of Minnesota a number of years ago, and I really liked it, so I tracked it down. So on the left here is treating everybody the same. So these 3 kids all want to watch the baseball game. They get the same size box to stand on. That's treating everybody the same. Unfortunately, this little kid can't watch the game. He's too short. On the right is treating everybody fairly, which means everybody gets what they need in order to watch the game. That's treating everybody fair. We can't possibly treat people fairly if we treat everybody the same, because everybody's dealing with different issues. I know you think that I'm letting him get away with something I don't let you get away with, but you're able to do things that he has difficulty with. It's not a matter of talking about diagnosis. It's a matter of I'm trying to be fair and help each of you reach your best potential. And that's going to be different for each of you. It's a little overwhelming. I'll tell you, as a direct care provider, it is so much easier to treat everybody the same. Here are the rules. Here's what happens if you break the rules, period. It is so much easier to do that than to think differently with different people in terms of what they need. I know it's easier, but it's not helpful.
Dan, we have just a quick question that kind of goes with that is someone says many students feel dumb when they find out they're in special education. They wanted to know how may older students react when they find out they have an FASD.
That's a great question. And I'll tell you that most of the people who I have spoken with and met over the years who've gotten a diagnosis with an FASD, especially as they've been older, they feel relieved. And the first thing they often say is, at least now I know I'm not just stupid, or at least now I know I'm not just bad, because for years and years, they thought they were just stupid or just bad. So helping them understand what that means, what having an FASD means, and that it doesn't have anything to do with how smart somebody is, but how their brain works, and everybody's brain works differently. And talk about what their strengths and abilities are and building on those, I think is an important component to that. But that's because we don't want them to feel that they're just dumb and they're in the dumb class, or they're, because I hear that, I've heard that a lot over the years. And it's like, this is what we're trying to do, is figure out how to help you learn best. And for everybody, that's different. So as they get older, those who have been older and gotten the diagnosis, in many ways, it's been a relief for them. So thanks for that question. That was a great one.
I have one more.
Yeah. Okay.
It just goes along with all of these things, and how a therapist, because that is kind of your genre, is how does a therapist then take this the dependence part and the independence part and create a therapeutic model? Is that something you're going to be talking about, or that's a big question?
It's a big question, and it would probably take more time than I have. But one of the things is, if we recognize the issues in how the brain is processing information, then therapeutically, we're going to do things differently. So we're not going to sit and do talk therapy for an hour. Bill would, had a therapist who, he would go for talk therapy. He could talk for an hour, but it made no connection for him. Actually doing a lot of role playing, doing a lot of situational practice, taking them out into the real world and practicing different things with them. One of the things is that often they have no sense of space, how far they stand from somebody when they talk with them. And often they stand way too close to people, and people get either offended or they feel challenged. So it would be practicing how far you stand from somebody when you talk with them. It's building, as I know Peg said, we want to build interdependence, not independence. I used to train case managers, intensive case managers, and I would see treatment plans that say the long-term goal for a person was to live independently in the community. And I would say, I never want to see that as a long-term goal. That scares me. Because living independently means you never count on anybody for anything at any time in your life. I would really love to see long-term goals that say to live interdependently in the community, which means you know who you can count on for help when you go to, when you need it. And I think the goal for people with an FASD as they get older is helping them understand that asking questions and asking for help is a sign of strength. It's not a sign of weakness. And everybody needs help at times. And so that anytime you're not sure about something, anytime you need help with something, here's who you call, and here's your backup person, and give them a specific person and backup who they call. for any reason. And that can do so well, because that's the goal. But our focus is, no, they need to figure this out on their own. They need, right? Because that's the real world. They need to do, no, that's setting them up to fail. Anytime you're not sure about something, you call me. I remember hearing about a young woman who was in substance use treatment with an FASD and graduated from treatment, got an apartment, came back for an outpatient appointment, and told her therapist that she was having sex with the landlord, because the landlord told her if she didn't have sex with him that she would get evicted. And she said, I wasn't sure, but I don't want to lose my apartment. If we could have built in for her, anytime you're not sure about something, you check with me first. And the same is true as they get, and starting really young in terms of social media, which is a huge concern for me in FASD, because they are very naive and gullible. Is building on that, anytime you're not sure, anytime you get a message, let's look at it and see if this is a safe person or not. Let's see if we can check and see if this is who they say they are. So all of that, it's not, and people have said, well, if they have FASD, they don't benefit from therapy. Oh, yes, they do. But supportive therapy, not psychoanalysis, but supportive therapy. So there are definitely ways of doing it. Using art and music and dance therapy can be very, very effective. Movement therapy, very effective. So but again, it's modifying it, maybe having shorter sessions. So there are a lot of other ways we could talk about it. Another great question. Is that it, Anne, for now?
Yes, that's it for now. Thanks, Dan.
Okay, thanks so much. Thanks for interrupting me. Okay, so again, we need to re-examine our thinking and practices. So if we get somebody to pay attention to FASD at all, this is how they may see it. Okay, so somebody has bipolar disorder, or somebody has another mental health disorder, and they have a learning disability, and they have FASD. We know that we need to recognize them all, and we need to address them all, but the typical approach is we do that in parallel. Here's how you treat the mental health disorder. Here's how you treat the learning disability. Here's how you treat the FASD. When it comes to FASD, that doesn't work. When it comes to FASD, this is the view. So let's say they have, again, bipolar disorder. Let's say it's a 15-year-old who has diagnosed with bipolar disorder. Again, you can't use cognitive behavioral therapy the way it was developed. If they have PTSD, you can't use trauma-focused cognitive behavioral therapy the way it was developed. You could modify them understanding the FASD, but you can't do that. And just give them their medication and say, here, you have to take your medication. If they have a learning disability, we need a different approach to address the learning disability with lots of modeling and lots of role play and lots of repetition, as you'll see. If they are homeless and they have an FASD, we can't provide housing for them and say, now you have to keep your housing clean. You have to pay your rent every month. You can't have any alcohol or other drugs in your housing. And you have to meet with the housing director once a week. We're just setting them up to fail. Because if they have an FASD, it tells us their brain is working differently. We need to do something different. So here are likely co-occurring disorders with an FASD, again, because of the genetic vulnerability. So ADHD, along with schizophrenia, depression, bipolar disorder, and substance use disorders. And I already talked about that, because in true ADHD, attention deficit hyperactivity disorder, with or without hyperactivity, 75% of the time, there's a first or second degree relative with ADHD. ADHD is one of the most overdiagnosed and one of the most underdiagnosed disorders there is. But even if these are truly co-occurring, it means the treatment for these needs to be different. They often have those sensory issues in all 5 sense areas. There may be certain smells that just set them off and they have tantrums or rages. And we don't even think of it in terms of the smell. It may be the certain fabrics they can't stand. Bill used to rip all of his shirts, and because this was clearly destructive behavior, I needed to consequence him for it, until I realized that what he was doing was ripping the tags out of his shirts. This is before tagless clothing, because he couldn't stand the feel of the tags. And when I cut all the tags out of his shirts, he didn't rip any more shirts. This was not willful destructive behavior. This was a sensory issue. So tagless clothing is really good. But even with tagless clothing, there are seams on the inside of clothes. So sometimes turning clothes inside out may be beneficial. Again, things like, touch and texture and taste and all 5 sense areas may be affected. They may have a reactive attachment disorder if they've been moved around a lot from place to place to place, but you'll see it may also be a misdiagnosis. They may have, again, a separation anxiety disorder if they've been moved around, because we move kids around like they're chess pieces and we don't deal with loss and grief issues. They may have post-traumatic stress disorder, but again, traumatic brain injury, and as adults, they're at risk for borderline personality disorder. And they're 5 to 60 times more likely to have been born with a seizure disorder, cleft lip or palate, have certain heart abnormalities, scoliosis, because prenatal alcohol exposure can cause some of those things. So even if these are co-occurring, our approach to them needs to be different, understanding the FASD. But in addition to the co-occurring, there are misdiagnoses. An ADHD, oppositional defiant disorder, and then somebody grabs them, they hit them, then they get a diagnosis of conduct disorder, and reactive attachment disorder are what I call like probably the 4 most common misdiagnoses. So if it looks like ADHD or it looks like an oppositional disorder, we'll just treat it as an oppositional disorder. Does it matter if it really is? We'll just treat it as ADHD and give them stimulants. Does it matter if it really is? Well, from my point of view, it does. And Bill taught me I needed to be more visual, so I started doing charts. I have lots of charts. I'm going to do this, show you this one here. So let's look at 3 individuals and think about 3. It could be any age. You've given them 3 instructions and they haven't done what you've told them to do. At home, it may be go upstairs, brush your teeth, get in your pajamas, get ready for bed. In school, it may be take out your math books, turn to page 43 and do problems 1 through 10. Whatever it is, you've given them 3 instructions, they haven't done it. So the behavior is exactly the same in these 3 individuals. One has a true ADHD, one has a true oppositional defiant disorder, and one has a true FASD. And for this example, they don't have co-occurring disorders. Sit down with the individual with a true oppositional disorder and say, what did I tell you to do? They can tell you what you told them to do because they took the information into their brain, stored it in their brain properly, and could recall it when they need it. Then you say, well, then why didn't you do it? I didn't feel like it. If it is truly an oppositional disorder, which means it's a conscious decision to not do what they're told, this is where reward and consequence can be effective. But you also want to give them a positive sense of control. You need to do this, you can do it now or in 5 minutes. Especially as they get into adolescence, one of the most important things is giving them a sense of positive control and choice. It doesn't mean you can do it or not, but maybe you can do it now or you can do it in 5 minutes. I'll set the timer for 5 minutes. Sit down with the individual with a true ADHD. You might have to help them focus, but they can tell you the 3 things you told them to do because they took the information into their brain, stored it in their brain properly, and could recall it when they need it. Their problem was they got distracted. So they went to get their math book out, but they pulled a notebook out instead. And then they started looking through the notebook and there were pictures drawn that they had drawn in the notebook. And then the youngster next to them rustled some paper, so they turned in, they looked at them, they got distracted. But if you can keep them on target by limiting stimuli and providing them with cues, they know the 3 things you told them to do. If it doesn't work environmentally, they may need medication to help them filter out stimuli and focus. And that's where stimulant medication can be really useful in true ADHD. Sit down with the youngster with an FASD. If you ask them the wrong question, especially with anyone over about 8 or 9 years old, which is, why didn't you do what I told you? The answer is going to be, I didn't feel like it. Now, I've worked with lots of kids and adolescents over the years in lots of different settings, as I said, and they have told me over and over again in their words, it's better to be seen as bad than to be seen as stupid. And it's better to be seen as bad than to be seen as crazy. And those are the words that they use. And they're absolutely right. I'll tell you, that even in California, if you're sitting in a high school class and you're not following what the teacher is talking about, act out. I can pretty much guarantee nobody is going to stop and ask you whether you understand the teacher. We're going to deal with the acting out behavior. Better to be seen as bad than to be seen as stupid or crazy. And those are their words. And they're right. So, but if you ask them the right question, and then it feels like it's just purposeful oppositional behavior, and then we provide them with some consequences. But if you ask them the right question, which is, what did I tell you to do? They can't tell you, because in FASD, the difficulty is taking information into the brain. Even if it gets into the brain, it doesn't get stored properly. And even if it gets stored in the brain, they can't recall it when they need it. So if the reason they're not doing the 3 things you told them is because they don't remember what they were, then providing them with limits and consequences is not going to help. Even limiting stimuli and providing them with cues is not going to help if they don't remember the 3 things they were told, but breaking it down to one direction or one step at a time. So you can tell the class, take out your math books, turn to page 43 and do problems 1 through 10, and then walk up to this youngster who's sitting in the first row close to you and say, Mary, could you get your math book out, please? And if Mary can't find her math book, because now she's in high school and she's supposed to have responsibility for holding on to her books, don't give her a 0. Here, Mary, here's a math book that you can use today. Could you turn to page 43? The page numbers are on the bottom there. And then when she gets to that page, now you take out your little Post-it and say, put a Post-it at the first question and a Post-it at the last one you want. Now I want you to answer these questions between those 2 Post-its, the 10 questions here. So you can do that in a larger class and focus on one direction or one step at a time. You know, at home, again, I would give Bill these multiple directions. He wouldn't do it. I would say, why didn't you do it? Because I didn't feel like it. And he would constantly get consequence. My typical consequence was being grounded for a week. And at 27 years old, he was still grounded for 23 years because I kept doing that. It took me a long time to figure out something's wrong here. And then when I finally told him the 3 things I wanted him to do, and then went up and said, Bill, what did I tell you to do? He had no idea. But when I broke it down, and he had a diagnosis of oppositional defiant disorder and ADHD and reactive attachment disorder at the time. But if I broke it down to one direction at a time, and we did it together, so I would model for him how to do it, he had no problem. He didn't refuse to do it. It was not oppositional. It was a memory issue. So really the most important question, I always say this, the most important question to ask for any behavior with any individual, not just those with an FASD, is what is causing this behavior? Because the same behavior has different causes for different people. And the same behavior has different causes for the same person at different times. But if you can't figure out what's causing the behavior, you can't get to the right approach for that behavior. And that's why you can't treat everybody the same. So I used to write and teach courses on youth and violence. And in doing the research for those courses, I found there were a number of people in jail because of violent behavior where they found tumors in the hippocampus or the amygdala of their brain, which are 2 structures of the brain that help control aggression. And when those tumors were removed, they had no more violent behavior. And then there was a young girl who murdered her stepsister. And they found that piercing cries set off seizure activity in the temporal lobes of her brain. And when that seizure disorder was correctly treated, she had no more violent behavior. Those people, they could be consequence for the rest of their lives. It would never get them to change their behavior. Because for the ones with the tumor, it was a medical issue. And the intervention was not to put them in jail. The intervention was to take out the tumor. And the intervention for that young woman was to recognize and treat the seizure disorder. So keep that in mind. What's causing that behavior is an essential question to figure out. And we often might need the whole team, the family and the practitioners to figure that out. I'll skip that. Here are other common misdiagnoses. adolescent depression and especially adolescent bipolar disorder, because often that looks like antisocial delinquent behavior. And in FASD, what happens is they get rejected by their pro-social peers. They gravitate to the gangs, the negative peer groups who see the neon sign on their forehead that says sucker and can manipulate them. And then they model that behavior. Autism and high functioning autism. When I see somebody diagnosed with autism who comes and is very friendly, gives me a hug the first time they meet me, talks my ear off, my antenna go up and say, doubtful that that's really autism. But it is so much safer to get a diagnosis of autism than a diagnosis of FASD. But the problem is then they get ABA and applied behavior analysis, and it's not going to, it's a token economy approach, which isn't going to be effective for most people with an FASD. Now, I know there'll be somebody saying, well, but this child with FASD really does well with that token economy approach. Again, not everybody with an FASD is exactly the same, but for the most part, and it all has to do with brain functioning. They may have a co-occurring reactive attachment disorder, but they may also have a misdiagnosis of reactive attachment disorder. And again, you need to know which it is because you need to know what you're treating. Unfortunately, because of time, I can't go over this, but this was a study that was done by 3 adults with FASD. They did an international study where they sent out a survey to people around the world. This was their health survey, the first one that they did. And it was Miles Himmerich and CJ Lutke and Emily Hargrove. And it's published in a social work book. But if you look at this, the general prevalence of these mental health issues and the frequency in FASD, for anxiety and agitation is so much higher in FASD. And I talked about why. Panic disorder is so much higher. Agoraphobia, OCD, obsessive compulsive disorder is higher. Attempted suicide is much, much higher. So recognizing that, and they had over 450 people respond to the survey. So it's not just like an N of 5. So we're going to see these mental health issues in FASD, but we have to treat them differently. And then the use of alcohol or other drugs, often to self-medicate, because it's so painful to have a hidden disability that nobody recognizes. So I know I still have a lot to do. I have 14 minutes. So I apologize. I always put way more than I can get to. But I want to go over, and I know Peg did some of this, I want to go over the brain damage, because the experts in brain research and FASD have said that the behaviors we typically see are caused by the way the brain is functioning. And they are not then willful, purposeful behaviors that need to be consequenced. We need to understand why we're seeing these behaviors. So if we understand the brain basis, then we can develop appropriate interventions. And again, I talked about why these other the reward and consequence approaches not only won't be effective for many of them, but will really be contraindicated, because all it will do is reinforce an image that they're the badass. That becomes their self-image, and they then sabotage anything positive that happens because it doesn't fit with their self-image. So one of the things, I may have it later, but I probably won't get to it, is another one of my major issues is we have to start telling those with an FASD consistently every single day what they've done right. They've heard over and over and over again in school, at home, in other settings, what they've done wrong. And we focus on the challenging behaviors and the things that they're not doing right. And often they have never heard what they've done right. I often say to parents, I want you to tell your child, at least let's start small, 5 times a day what they're doing right, and write down everything you tell them. Because when things go wrong, you'll forget any of that, and they'll forget any of that. We want to build their self-esteem and confidence, that there are things that they can do, that they do well, because they have such great strengths that we want to tap into. So There's damage in the part of the brain, the dorsolateral prefrontal cortex, that's responsible for immediate or working memory. That's what we rely on whenever we tell somebody to do something. This is why you give them multiple directions and they can't follow them, especially if it's verbal, because verbal receptive language, as Peg said, is more impacted than expressive language. But that difficulty in taking the information into the brain, storing it properly, and recalling it when they need it. So because you've given them multiple directions and they don't follow through, they're seen as oppositional and they need to be consequenced. So recognizing the damage in the dorsolateral prefrontal cortex of the brain means we give them one direction at a time, one step at a time, one rule at a time. And it also means now long-term memory is less impaired, but it takes a tremendous amount of repetition, and consistency to get it past damaged working memory into long-term memory. So again, when you get frustrated, we went over this 5 times already. Do we have to go over it again more? Yes, because of the damage in working memory, not because they're not paying attention. We need to get it past damaged working memory. There's also damage in the area of the brain responsible for the ability to recognize danger and fear and know what to do. That's the amygdala of the brain, which, as I said earlier, has responsibility for controlling aggression as well, and also stress and anxiety. So as young kids, they tend to have no stranger anxiety. As they get older, they don't recognize dangerous people and dangerous situations, and they put themselves at high risk of abuse and trauma. So telling them don't talk to strangers doesn't work, because that's if they don't know, you know, as soon as somebody tells them their name, they're not a stranger, they're their best friend. Don't put yourself in a dangerous situation. You get beaten up by that person, you'll know not to go back to them. No, that doesn't work. What we may need to do is figure out situations they may get into that are dangerous, and let's role play what to do in those situations. Let's build that anytime you're not sure, you come and talk to me. And if I'm not available, here's who you talk to. You know both of us, you feel comfortable with us. It may be a professional, it may be a family member, it may be a friend. There's difficulty in the frontal lobes of the brain in abstract thinking. And again, this is across the IQ span. They tend to be very, very literal in their thinking. And if you are literal, if you don't get abstract thinking, you don't get a sense of historical time and future time. And if you don't get a sense of historical time and future time, you don't get cause and effect, and you don't get reward and consequence. You can't get this now because of what happened before. If you want something later, you need to do this now, because the answer is often, but I was good just now. I would ground Bill for a week at a time. He would come down 15 minutes later and say, can I go out now? With a big smile. And I would say, can you go out now? I know, you know what you did wrong. You know why you're grounded. Now you're grounded for 2 weeks. And he would look at me and say, but Dad, I didn't do anything just now. And the steam would come out of my ears. And I would say, now you're grounded for 3 weeks. He was absolutely right. He was good for 15 minutes. He had no idea why he was being grounded, because they don't get cause and effect. They can't predict the consequences of their actions. So they keep on getting in trouble with the law. Somebody tells them, here, I'm sending this photo to you, send it to your friends. Sure, no problem. They can't predict, oh, no, that's not the right thing to do. So they also don't get that sense of historical time and future time. So they keep changing their story in terms of when something happened, where it happened, how it happened, and they're seen as lying all the time. So they're dismissed as being a victim. They're dismissed as being a witness to something, and they're not believed when they're charged as a perpetrator and they say they didn't do it. Well, where were you then? And then they, can't remember when then is, because if you don't get that sense of time, how long ago something happened. So it's not always that's why we always need to verify stories. And then I talked before about often they don't get the sense of space, how far personal space. Talk about an abstract concept. And if abstract thinking is impaired, you're not going to get that. Again, as I said already, they can't take what they learned in one situation and apply it to another. So I always say, if there are parents who have an FASD themselves, never send them to parenting classes, because that's the biggest waste of time, money, and energy. I say that to child welfare all the time. biggest waste of time, money, and energy there is, because they can't take what they learn in a parenting class and apply it 4 hours later or 3 days later or a week later when something comes up with their kid. In vivo parenting is the only kind of parenting help that works. Again, damage to the parts of the brain responsible for the expression of emotion, which are the hippocampus and the caudate nucleus of the brain. So somebody gets hurt and they start laughing. You're talking with them about the seriousness of what's happened, and they're smiling or they're laughing, and we think that they have no conscience or no remorse. But what I see often is that it's a disconnect between what they are feeling and how that feeling is expressed facially and verbally. And that's often due to difficulty in the early development of affect regulation, which begins about 2 or 3 months of age, where they're modeling the affect of their primary caregiver. And if that doesn't develop well for whatever reason, either the caregiving reason or the individual's reasons, that they can't take the information in, then they don't develop good affect regulation. And that's that ability to put words and facial expressions to the entire range of feelings. And then we need to model that. So we can't go into work when we are really sad about something and say, I'm really sad today, with a big smile. That's not modeling good affect regulation. And then there are systems that control stress and anxiety. So what we have found is that there's an over-release of a hormone called cortisol under minor stressful situations. So with minor stressful situations, they tend to overreact. And we say they're doing this on purpose and need to be consequenced for it. No, we need to recognize this is a physiological body response. This is not a willful behavior. Somebody bumps into them, as they say, they haul off and punch them, kick them, stab them, hit them, because they feel it as an attack. There's a change in their schedule. There's a substitute teacher and they're acting out. And you know, you have kids, those of you who work in education, who have kids who every time there's a substitute teacher, they get into trouble. They're acting out in class. They're disrupting the class. If that were the case, what I would say is, when there's going to be a substitute teacher, have somebody meet this kid at the door to school when they come to school in the morning. Take them, and it's somebody who this kid likes. Take them into an office, maybe the janitor, maybe a maintenance person, maybe the vice principal, and talk about, you know, you're going to have a different teacher today because so-and-so is out. These are the things that are going to be the same. You're going to have PE at the same time. You're going to have recess at the same time. You're going to have lunch at the same time. But there may be some things different because it's a different teacher. Anytime you're worried about something, you're not sure, you ask the teacher for a pass and she'll give you a pass, or he'll give you a pass to come and see me. And the response from teachers may be, no, that's rewarding bad behavior if I give them a pass. No, the key is recognizing when they need that break. Now, the other thing is they get overwhelmed easily and overstimulated, overwhelmed, and then they shut down or they act out. So the teacher's role is really to pick up when they're losing it, and they may need a break. So they need many breaks, 15 minutes and then a break. Oh, I see you need a break. Go take a break. Or maybe give them a signal that it's time to go take a chill out for 5 minutes. There's also damage in the ability for messages to get transmitted in the brain. That's the myelin that coats all the nerves. So what happens is that it takes them longer to process information. So we say, I know that there are a couple of parenting techniques, for example, that say you give your child a timeout. If they don't respond within 5 or 10 seconds, you add timeout. That's never going to work in FASD. I mean, the timeout's not going to work. Time in is much better. You need time in, come here and let's talk about what happened. But because they don't respond right away, because it takes them time to even, and it doesn't mean they're not willing to, you have to give them more time to process the information, to get the information processed in the brain. And then although they will laugh at a joke with other people, they often don't get that people are joking with them. And they think the person hates them or is out to get them. I could always tell when somebody was joking with Bill and he would think that the person hated him. And I would say, Bill, they're just joking with you. Don't take it seriously. Oh, they are, Dad? Okay. And then he was fine. But he would laugh and people assume that. And his 4th grade teacher, years after he got his FAS diagnosis, said, you know, thinking back, another kid in the class would tell a joke. Bill would laugh along with the rest of the class and then turn to me and say, I don't get it. What's so funny? That's a red flag we totally missed. So I know that Peg talked about stigma. I think it's really, really important to pay attention to the stigma because those with an FASD and families experience so much stigma around this. And it affects how they function and it affects getting help. So we want to model appropriate. So we want to use person first language. Nobody is FAS, but somebody may have FAS. Nobody is schizophrenic. Nobody is adopted. They may have been, you know, they may be a child who has been adopted, but they're not the adopted child. Because that's not person first language. And we want to see everybody as a person who has an issue. Even people, I would rather somebody say, you know, I have an addiction than I'm an addict. Because that's not who they are. That's not their identity. They're a person with strengths and abilities who has a disease, an addiction. So again, the cognitive impairments that are in FASD, which don't have to do with IQ, again, interferes with that person, that ability to be successful. So we need to modify things. Difficulty with approaches based on verbal receptive language processing. So they're only taking in every 3rd or 4th word that you're saying. Then they're filling in the blanks with what you think they said, what they think you said, what they think you want, and they're getting it wrong. And then they're looked at as being willful and purposeful. So again, behavior due to prenatal alcohol exposure is often caused by the damage to the brain. So all interventions need to be modified, taking into account how the brain is processing information across the IQ span. We need to modify their environment to help them reach their full potential. I used to say to succeed, but success is different for different people. So now I say to help each individual reach their best potential. And we want to use a strengths and strategies approach. And that's what I work with agencies, and that's what I do is build that approach of screening for a probable FASD and then using a strengths and strategies approach, where the first step, if they screen as having a probable FASD, is doing a strengths assessment for the individual, the family, the providers, and the community, because that's what we want to build on, is the strengths. And then strategies based on connecting the strengths and using strengths and strategies to address challenging behaviors and modify the environment to address the challenging behaviors. So we need to be patient, encouraging, hopeful, supportive, committed to developing relationships, non-judgmental, non-punitive, creative and flexible, able to use humor appropriately, and able to identify strengths. Again, this was from the Alaska FASD 201 curriculum. So it's essential to really care, find what you like about this youth or this adult, because they do have real strengths. They may drive you crazy, but you say, but you know, and my first question is often, if you ask them to help with something, are they willing to? Oh yeah, they really are helpful. They really like to be helpful. That's a great strength. Try asking them to do something instead of telling them to do it. You may get a totally different response. If I said to Bill, go out and mow the lawn as an adolescent, or you will be grounded, 10 years later, he would still be grounded and the lawn wouldn't be mowed. If I said to him, Bill, I need help mowing the lawn, would you mind helping me? In 5 minutes, he'd be out mowing the lawn. But we get caught up in, no, they have to do what we tell them to do, the way we tell them to do it, when we tell them to do it. That's why we need to change what we do, as opposed to expect them to change what they do. Acknowledge the positives. We need reminders of what's been accomplished, especially when things aren't going well. So here's Bill at 14 years old, he's in the stocks. Here he is at 27 years old, still in the stocks. Some days it feels like nothing has changed. That's when you have to take out the list of all of those strengths that we've identified. And remember that recognizing FASD and addressing it can literally be a matter of life or death. So everything you do, whether you are a teacher or an aide or a therapist or a parent or anybody, Everything you do makes a difference for individuals with an FASD. And we can save people's lives by doing this. And you may not see the impact right away, but it will come back years later, maybe. So that the people I have met over the years who have really struggled, the adults with FASD who have really struggled and maybe been in jail multiple times, been, had substance use issues, those who are doing best are the ones who said that throughout everything, they had somebody there who stood by them for support, for help when they needed it. And that's really key. Somebody who go to appointments with them and talk about what happened. So even if you're a teacher, and I know I'm over time and you have to have lunch, but even if you're a teacher and you're giving a lesson, then spend 5 minutes at the end of the lesson, if you can, when maybe the kids are doing something else, talking with this kid and going over what happened in that lesson and what that means for them. That's the piece that they need help with. So thank you for listening to me. I hope this has been helpful to you. Again, this is what I do. I do consultation, coaching, and training. If you want to learn more about that or the agencies that I've worked with that are implementing this and how they're doing, please feel free to contact me. Just know that the S and the K in my email address are the reverse of the S and the K in my name. So thank you. I know you have 2 more incredible speakers today that I'm really excited for you to hear. Stephen Greenspan and Deb Evenson. So enjoy the rest of your day, and thanks again. And I'll turn it over to Anne or Peg. Someone?
I'm coming.
Anyone?
Thanks so much, Dan. Everybody will be taking a hour break. And we'll see everybody back at 1 o'clock, a little less than an hour, but we'll see everybody back at 1 o'clock. Thanks. Thanks, Dan.
Sure. Hi, Deb.